Evening, everybody. Good evening, everybody, and welcome to the SAGES SCORE ABSITE webinar. This is our 7th annual year of hosting this wonderful event. This is part 1, and we're going to have part 2 here in a second. It's great to have you all here. I know it's a busy time of year for everybody, holidays and everything coming up, but we have had the privilege and honor of hosting this for many years, and I have a tremendous set of panelists that have joined today. We'll kind of introduce them as we go along, but really excited to have everybody here. A couple ground rules before we get going. Again, my name is Michael Awad. I'm a minimally invasive surgeon here at WashU in St. Louis. I'll be kind of your co-host for this evening. We are recording this session, and so there will be an opportunity to review it after it gets posted to the SAGES website. There is the chat and a Q&A that we'll be monitoring. We won't be able to take questions verbally, but if you post things there, we will attempt to answer either by text or as we're able to. Unfortunately, we won't be able to answer necessarily every single question, but we will try to get to as many as we can. This is meant to be an interactive format, so we are going to have questions, and we're going to go through them pretty rapidly as we do have a number of questions to get through. And with that, I'm going to pull up our slides here that we're going to be going through. So again, welcome to our ABSITE SAGES SCORE webinar. I do want to thank SCORE, the Surgical Council on Resident Education, which I think most of the residents in the US and many worldwide know very well. SCORE, we've had the privilege of having this collaboration with for a number of years, who provides us with the questions for these webinars, and we get a fresh batch really every year. This is the agenda for our program this evening. We will have 4 topics that we'll go through. I'll be kicking us off with esophagus, stomach, and obesity. Dr. Jeff Flatnick will be covering general abdomen, hernia, and spleen. Dr. Amber Traugott is going to go over colorectal and anal disease, and Dr. Tim Vreeland is going to go over small intestine, biliary disease, and flex endo. I do also want to make a comment about SAGES, which is the Society of American Gastrointestinal and Endoscopic Surgeons, one of the largest surgical societies in the US and in the world, and is the co-host of this webinar this evening. SAGES, for those of you unfamiliar with it, is an amazing organization that we hope you consider getting involved if you're not in it already. The vision, mission, and values are listed here, and you'll see that the values include inclusivity, innovation, service, excellence, global community, and of course, fun. SAGES membership brings with it a lot of benefits, including a discount to the annual meeting, some of the best educational resources that you'll see out there with courses, videos, online resources, network of over 7,000 members across the world that you can collaborate with and communicate with. Surgical endoscopy, the journal for SAGES, to get an online subscription to, grants and career development awards, and a number of other opportunities. There are a number of different membership categories, including for residents and fellows candidate membership, which is very economical. I think it's only $70. You can even stay as a candidate member for up to 3 years after you graduate. And finally, I want to plug the National SAGES meeting coming up in March in Denver, Colorado. This is one of the most kind of fun and kind of jam-packed meetings that you can attend. It's going to be held in Denver. It's a terrific program that's shaping up. We hope that you can make it and join us this year. So again, I mentioned SCORE. Again, very grateful to their partnership with this program this evening. This is the ABSITE content outline, and this tonight's topic, we're going to be covering these topics at the top of the list here. In ABSITE webinar part 2, which will be January 11, 2022, same time, we're going to be covering the rest of these topics that you see on the list here. Together, between the two webinars, we cover over 75% of the topics on the ABSITE. The format for those of you that are unfamiliar for this, if you're new this year, we're going to have multiple choice questions. We're going to use the built-in polling system within Zoom. So look for a poll that pops up on your screen. For those of you on your smartphone, you may have to toggle back and forth between the poll and the question. And we're also going to go over the answers and discuss them as well. So again, I'll be kicking us off with esophagus, stomach, and obesity. And I'm just going to pull up my chat here so I can keep that open, in our Q&A box so we can keep that open. All right, so let's go ahead and dive in. So I have the first question up for us today. So this is a 45-year-old man who is referred to you with a chief complaint of dysphagia that has been worsening over the past 6 months. His daily complaints of chest pain and regurgitation, 10-pound weight loss, has had no prior workup. Which of the following management approaches is most appropriate? We can bring up the first poll. A, no additional testing. Go straight to an esophagomyotomy with partial fundoplication. B, upper GI series alone. C, an upper GI series, EGD, and manometry. D, upper endoscopy alone. E, chest X-ray and clinical exam first, followed by pH probe testing. Good. So I see a number of you answering in the poll. We'll give a couple more seconds, and then we will discuss. All right, very good. Vera, let's go ahead and show the responses. And hopefully those are showing up. It looks like most people answered C, which is the correct answer. Upper GI series, upper endoscopy, and manometry. And so this patient has dysphagia, which obviously has many causes, benign and malignant. Some are oropharyngeal causes, some are esophageal causes, and we really have a wide differential here. The best series of tests to initially identify this are listed here. An upper GI series, which can show kind of anatomy. It's not very good or sensitive at looking at motility. And so for that, an esophageal manometry is still the gold standard. And an upper endoscopy or EGD can help look for mucosal abnormalities, the extent of esophagitis, malignancy, or other pathology. Some additional workup might be needed in addition to this, which might include a pH probe or a gastric emptying study, but these tests are the initial best tests to work up this patient. Our next patient is a 72-year-old man with a history of pulmonary hypertension, stage C heart failure with onset of chest pain after multiple bouts of emesis. He's in the emergency department. His blood pressure is 90/63, tachycardic to 115. CT of the chest shows a small left-sided mediastinal fluid collection. After initiation of antibiotics and resuscitation, what is the most appropriate treatment option? A, upper GI swallow study. B, endoscopy with placement of covered stent. C, operative exploration and wide drainage. D, primary repair through a thoracotomy. Or E, consult to palliative care. We'll give a couple more seconds. A lot of responses coming in. All right, So the correct answer for this one is B, endoscopy with placement of covered stent. And I do see there's a bit of a spread on this one. So let's talk about this a little bit. So the key is here that there's a patient with a number of comorbidities. He's got pulmonary hypertension, stage C heart failure, and that certainly impacts the choice here. A lot of these ABSITE questions have multiple, sometimes correct options, but will depend on other factors like this patient who has comorbidities. In this case, they probably wouldn't be a good candidate for operative exploration, wouldn't tolerate that. And so covered stents are a viable treatment option with a really fairly good success rate, quoted at 88% for treating these esophageal perforations. The upper GI swallow is a good way to confirm the diagnosis, but won't treat it, and certainly observation is not appropriate. The goals of care is always important to have, but a palliative care consult is really not warranted at this time. Next question. 57-year-old woman presents to your clinic with a history of long-standing GERD, for which she's been taking proton pump inhibitors for 15 years. The symptoms are well controlled on these medications. You do an upper endoscopy and you see velvety red tongues of mucosa that extend proximally from the GE junction onto the distal esophagus. Biopsies are taken and confirm histologic change of the mucosa to a columnar configuration. After counseling the woman regarding her condition, you learn she does not want surgery. When should the next endoscopic surveillance be performed? A, within 6 months, B, within a year, C, within 2 to 3 years, D, within 5 years, or E, within 3 months. All right, let's go ahead and discuss this one. Good. So let's talk about this one too, as we have some spread. So the correct answer is within 2 to 3 years. So this is a patient with Barrett's esophagus with long-standing reflux. It's, again, the columnar configuration is the key that this is Barrett's. If esophagitis is suspected, you do 4-quadrant biopsies. This is the Seattle protocol at 2-centimeter intervals and send for histology. If there is dysplasia, then that increases the risk of adenocarcinoma. However, there is no indication of dysplasia or certainly cancer in this patient. As a result, surveillance every 2 to 3 years is warranted, unless you have symptoms that are not controlled with medications. So key point here is this is just simply uncomplicated Barrett's, no dysplasia, no cancer. All right, next question. A 77-year-old woman is undergoing a laparoscopic paraesophageal hernia repair. The hernia sac is dissected and the GE junction is reduced appropriately. However, there is a wide gap of the hiatus and it is really impossible to close it primarily. What is the best next step? A, use a synthetic mesh to bridge the hiatus. B, leave the hiatus open and perform a fundoplication. C, perform a diaphragmatic relaxing incision to allow for crural approximation. D, convert to a Roux-en-Y gastric bypass. Or E, perform a gastropexy. And while we're waiting for answers to come in, I see a question in the Q&A from Dana. Would the answer be different if patient symptoms were not controlled on medications? Yes, I think if they were not controlled, it would just be like a symptomatic GERD patient. Typically, I give patients about 6 months to have medical therapy, and if they're not adequately controlled, then we start discussing surgical options. Okay, so let's go ahead with question 4. The correct answer is C. Perform a diaphragmatic relaxing incision to allow for crural approximation. A number of you also considered A as an option, which is use a synthetic mesh to bridge the hiatus. A mesh, by mesh, I should just clarify, this is an absorbable product in either a biologic product or a synthetic absorbable product. We don't use permanent non-absorbable plastic mesh at the hiatus. But the point of this question is that we don't really create a bridge, because if you leave a gap, there is still a high risk of recurrence. As soon as that mesh absorbs, it's almost certainly to recur. So we do need to get those cur together, and a relaxing incision is typically done. Now, after we do that relaxing incision, a lot of times we will reinforce that with a biologic or synthetic absorbable mesh on top of it. And then you still have to close the gap created by the relaxing incision. And for that, I do use a plastic mesh, but that is not next to the esophagus, not covering the hiatus. Good question. All right, next question. This is a 6-year-old child brought to the emergency department after ingesting an unknown liquid. The mother reports that the kitchen cabinet was open. The child was found coughing and vomiting. What is the first step in management of this situation? A, placement of an NG tube, aspirate and send for analysis, followed by lavage. B, induction of vomiting. C, initiation of antibiotics. D, protection of the airway, or E, performance of endoscopy. All right, good. Let's show the answers. So for this one, looks like most of you got this correctly. Always, always, always go back to your ABCs, right? Protection of the airway is first thing. What about the other options though? So keep in mind that placement of an NG tube. So by the way, this is a suspected caustic injury to the esophagus. So again, airway protection is key. An NG tube or OG tube should be avoided as they can lead to further injury of the esophagus. Induction of vomiting can lead to additional injury of the esophagus. Antibiotics can be helpful, but again, it's not the first step. And again, endoscopy can also risk perforation or hemodynamic instability. Next question. A 60-year-old otherwise healthy man is diagnosed with a well-differentiated 1.5 centimeter esophageal adenocarcinoma in the lower third of the esophagus. It was found on surveillance endoscopy for Barrett's. Staging reveals tumor invading the submucosa but no involved lymph nodes. PET CT scan reveals an area of increased uptake in the region of the tumor alone. Which of the following is the best treatment modality? A, definitive radiation. B, cryotherapy. C, radiofrequency ablation. D, esophagectomy. Or E, photodynamic therapy. All right, good. Let's go over this one. The correct answer, which most of you got, is esophagectomy. So this patient does appear to have local disease. There's no evidence of involved lymph nodes, no evidence of disseminated or metastatic disease. So this is considered a T1B, N0, M0, or a stage 1B esophageal adenocarcinoma. If they're medically fit, esophagectomy has been shown to have the best overall survival and disease-free survival. Some of these other options are to be considered if the patient is not fit. but they don't have quite the same success rate or outcomes. Next is a 63-year-old morbidly obese woman who presents to the office with complaints of frequent regurgitation of food that she ate a few days ago. She often has coughing and experiences dysphagia, especially to solids. Halitosis is prominent. She was admitted recently for right-sided pneumonia, which has been recurrent. Her body mass index is 54 with reduced hyomental distance. This is otherwise known as a short neck. Contrast, swallow demonstrates a 4-centimeter diverticulum in the neck. What is appropriate management of this patient? A, observation until the diverticulum reaches 5 centimeters. B, endoscopic transoral cricopharyngeal myotomy. C, open myotomy with a total diverticulectomy. D, diverticulopexy alone. Or E, myotomy alone. And Otto, thank you for your question. And Dr. Breland, thank you for responding. And I'm not sure if the whole audience can see the questions or if it's just going to hosts and panelists. Otto asked, does location impact surgical management? Lower, upper third. Dr. Breland responds, definitive radiation therapy for upper esophageal squamous cell. Okay, back to our patient with the diverticulum. The correct answer is C, open myotomy, followed by a total diverticulectomy. Let's talk about this one, as there were some different opinions here. I do like the folks who answered endoscopic transoral cricopharyngeal myotomy. That's certainly a viable option. That's a procedure I do as well. The thought, however, around this one is a couple of things. One is that the size of the diverticulum is quite large. So being a 4-centimeter diverticulum, there's concern that an endoscopic myotomy alone would still allow for food trapping in the retained diverticulum. Certainly myotomy needs to be done, and that's because of the underlying problem or that caused the diverticulum. But in this case, you would need to resect the diverticulum in order to also prevent pooling and trapping of food and fluid. Next, question 8. A 4-year-old boy is brought to the emergency department after swallowing a battery 2 hours ago. His mother noticed the back of a toy had an open door and the battery was missing. He appears comfortable with minimal symptoms. A chest x-ray performed an hour ago shows a round, flat, radiopaque object in the stomach that measures 2.3 centimeters in diameter. How should treatment proceed? A, order a CT scan. B, perform urgent endoscopic removal. C, observe the patient for passage of the battery in the pediatric ICU. Or D, repeat the chest x-ray tomorrow. Okay, correct answer is B. Good, most of you got that correct. Perform urgent endoscopic removal, and that's because these batteries itself can be caustic and cause serious gastric mucosal burns, fistulae formations, or perforations. This is in the stomach. It is retrievable, and so endoscopy would be reasonable to attempt and high likelihood of retrieving it. Generally, the criteria for ingestion of batteries include children that are 12 years age or younger. If it is 12 millimeters or greater in diameter, and for patients who the diameter of the battery is unknown. Asymptomatic patients require urgent endoscopy when the patient's less than 5 and swallowed a battery greater than 20 millimeters in diameter. CT scan doesn't really provide any information, additional information, and observation is not indicated given the patient's size and the size of the foreign body. Next is a 64-year-old man presents with hematemesis and substernal pain after an episode of binge drinking with associated forceful vomiting. Upper endoscopy is performed and an esophageal mucosal tear is seen with no active bleed or visible vessel. What is the appropriate next step? A, hemoclip application, B, balloon tamponade, C, band ligation, argon plasma coagulation, or E, observation alone. Questions about the diverticulectomy question while we're waiting. So the endoscopic approach, we want to talk about a couple of things for treating this. One is the size of the diverticulum. Generally, small diverticula can be treated endoscopically. 2 centimeters or so tends to be the cutoff, theoretically 3. One that's 4 centimeters is unlikely to be successfully treated endoscopically. You can staple the diverticular septum. However, with ones that are this large, you risk causing a full thickness perforation or injury to the recurrent laryngeal nerve. So for that reason, open is the approach. But back to question 9. E, observation alone is the correct answer. Most of you got that, although a few answered A. Without a visible vessel, adherent clot, or active bleed, endoscopic intervention is not indicated. The patient can simply be admitted for close observation. Next question. A 67-year-old woman presents to the emergency department with acute onset of nausea, epigastric abdominal pain, fever. She has a rigid abdominal exam and elevated white blood cell count, a history of a Roux-en-Y gastric bypass with poor follow-up, current tobacco user, occasional ibuprofen use, and no prior episodes. The patient has a CAT scan which shows free air. You evaluate the patient, discuss emergent operation based on what presumed bariatric surgical complication. A, perforated marginal ulcer, B, bleeding anastomotic stricture, C, internal hernia, B, vitamin B12 deficiency, or E, gastrogastric fistula with leak. Good. Let's go over this one. This one is indeed A, perforated marginal ulcer. Most of you answered that. A couple put down C. All of these are certainly kind of long-term sequelae or complications of bariatric surgery. Although in this acute setting, there's a couple of clues: the history of the NSAID use, the smoking use, the poor, follow-up, and the free air is what makes this one the perforated marginal ulcer. Internal hernia with bowel obstruction rarely results in a perforation, but A is the best answer in this case. All right, next question. This is a 55-year-old woman with diabetes complicated by peripheral neuropathy, presents to ED with acute on chronic epigastric pain, nausea, and vomiting. She's been experiencing early satiety for years and changed her diet to a strict vegetarian diet in the last few months. Following her workup, she's taken to the OR where you can feel a firm 8-centimeter mass impacted at the gastric outlet. The overlying gastric tissue feels thin with small patchy areas of questionable viability. What is your next step in management of this patient? A, endoscopic examination, B, Coker maneuver, C, anterior gastrotomy, D, distal gastrectomy, or E, Billroth 2. All right. I see we're definitely going to have to talk about this one. All right, so this one's a little bit of a tricky one, and there's a couple clues in this question, but certainly not necessarily straightforward. So the correct answer is C, intergastrotomy. This is a bezoar, and so again, you have an 8 centimeter mass. Is it benign? Is it malignant? Again, a little hard to say. The history has a couple clues. Patient with diabetes, with sequela of diabetes, including probably gastroparesis. This has been going on for years, and so it's less likely to be a malignancy, although certainly it should be on the radar. And when you go to the operating room, you find this 8 centimeter mass, and so you know that it's going to have to be dealt with. Endoscopy can be helpful, but you know that you're still going to have to resect the lesion. And so an anterior gastrotomy gives you the most direct approach to this lesion, which is a bezoar. Once it's extracted, then you have to look at the gastric tissue for viability. In this case, you can really feel the mass, so you don't need a Coker maneuver to mobilize it or to isolate it. A Billroth 2 is a reconstructive option and not really necessary in this case, typically reserved for peptic ulcer disease, not for extraction of a bezoar. So again, a little bit of a tricky one on this one, but history provides some clues. All right, I'd like to switch gears here, and we're going to move on to the hernia part of our program. For that, I would like to reintroduce one of my good colleagues and friends, Dr. Jeffrey Blatnick. Dr. Blatnick is a world-renowned clinician and researcher in abdominal wall core health and hernia disease, and fortunate to have him as one of my partners here at WashU in St. Louis. Dr. Blatnick, thank you so much for being a part of this again this year, and welcome.
Thanks for having me. This is such a great event. I really wish this was something we had back when I was a resident, kind of preparing for the ABSITE, and so hopefully you guys get a lot out of it. We'll kind of run this section similar to the way Dr. Awad ran his, and that I'll kind of read questions, go through the answer choices, and then depending on how everybody does, we'll either spend a little more time or a little less time moving forward. So with that in mind and kind of being on a time crunch, we'll go ahead and get started. So our first question is a 46-year-old male who presents with a 6-day history of worsening lower abdominal pain. He reports no fever, significant change in bowel habit, or other related GI symptoms. His biochemical and hematologic lab profiles within normal limits. CT of the abdomen pelvis reveals an ileocolic or an ileocecal mass suggestive of ileocecal intussusception. What is the most appropriate next step in management? A, admit the patient for conservative treatment and watchful observation. B, diagnostic laparoscopy. C, reduction with colonoscopy. D, image-guided percutaneous biopsy of the ileocecal area. Or E, PET scan to assess for malignant deposits. I think the thing with all these questions is really spend time looking at the details of what they give you. And then the last kind of question is always a key thing to look at. So what is the appropriate next step in management? So where do you go first for trying to help this patient who presents with acute pain? And so the correct answer here is diagnostic laparoscopy, which is good. 75% of you got that right. Just a few things about the other one. Obviously, he has acute abdominal pain, so observation, probably not the correct answer. Reduction with colonoscopy, that was number 2 from the group. That is something you would do in a pediatric population, not necessarily in an adult population. Although from a diagnostic standpoint, colonoscopy can be an adjunct, but not the way it's presented here. Image-guided percutaneous biopsy, not very easy to do, and PET scan would be something that can be considered later if a true malignancy is diagnosed. All right, next question. 27-year-old female presents with a slowly growing painless abdominal wall mass over the past 3 months. She has not noted any erythema, fluctuance, or drainage. She's eating normally without changes in her bowel habits. She has FAP, or family adenomatous polyposis, and underwent total abdominal colectomy with ilioanal pouch 4 years ago. A benign osteoma of her skull was diagnosed 6 years ago and has not changed. There is a 10-centimeter firm mass in the left lower quadrant adjacent to the previous surgical incision. CT scan shows a complex solid mass arising from the mesentery and invading the anterior abdominal wall. What is the next best step in management? I cannot see like the answers coming in, so I don't know where numbers are. So we'll just give it a couple minutes and then move forward with the answer.
No problem, Dr. Blatnick. I'll bring up the answer as soon as it looks like we are plateauing with the responses.
Great. The correct answer is C, core needle biopsy. And so a couple of key things in the stem here when you kind of look at it. She has FAP, she has a known osteoma, and has a new abdominal wall mass. So this is consistent with what's called Gardner syndrome, which is FAP with extracolonic manifestations, which usually includes a desmoid and an osteoma. And so in this situation, they want you to confirm the diagnosis first, which is where the core needle biopsy would come into play. Surgical excision is not necessarily wrong, but it can be very difficult given the size of the tumors, as well as in this scenario, they tell you that it's coming from the mesentery and invading the anterior abdominal wall. And so that can ultimately lead to complex surgical excision, potential need for bowel resection. So in this situation, you want to confirm the diagnosis first, which would be the core needle biopsy. Again, next best step in management. All right, question number 3. A 27-year-old male was involved in a motor vehicle collision. On CT scan, he's found to have a left diaphragmatic rupture with gastric herniation into the left chest, as well as a grade 4 splenic laceration with active extravasation. What is the best option to address the diaphragmatic laceration in this patient? So while that's coming up, we'll try to go and address some of the questions in the Q&A. Somebody asked for the previous question, which I assume would be number 1. Would your management change if you presented with 1 or 2 day history of abdominal pain as opposed to 6 days? I think ultimately you need to figure out what's going on, whether it's somebody you take to the operating room in the middle of the night or kind of assess the next day. But I think reducing the intussusception is certainly going to be key. And you can make the argument if it's been there for several days, he more likely will need a surgical intervention to reduce it along the way. There's always mixed things about doing core needle biopsy in these situations, but I think confirming the diagnosis is certainly most important to answer those 2 things. All right, so back to question number 3 at hand. Good 60% of you got the right answer. That's C, laparotomy and diaphragmatic repair using non-absorbable suture. The second most prevalent one was laparotomy and diaphragmatic repair using slowly absorbing suture. So a couple of things about this. Most people picked up on the fact that it's a grade 4 splenic laceration with active extravasation. That's obviously for most situations going to put you into the operating room. And then when you combine that with diaphragmatic rupture going through the abdomen makes the most sense. The problem with slowly absorbing suture in this situation is the diaphragm is very dynamic. And so you're breathing, things are moving. And most people agree that a permanent suture makes the most sense to reduce the risk for recurrent herniation down the road. Obviously, using mesh at this time is probably not the best option. All right, question number 4. Whew, it's a long one. All right, let's go. A 12-year-old boy with hereditary spherocytosis presents with increasing fatigue that has limited his activity. He also complains of intermittent upper abdominal pain with eating. His history is notable for a viral upper respiratory infection 3 weeks ago and a similar episode of fatigue for which he required blood transfusion 3 years ago. He takes no medications currently. He's received all of his appropriate vaccinations. Vital signs is 36, pulse 110, blood pressure is 90/60. He's pale with mild scleral icterus. Abdominal examination demonstrates firm, mildly tender mass in the left upper quadrant of the abdomen. The rest of his exam is unremarkable. His labs come back with a hematocrit of 24%, platelets of 105,000. His total bilirubin 6.4 and direct bilirubin is 1.2. He has an ultrasound that shows a very enlarged spleen. Mobile gallstones are noted in the gallbladder, but without evidence of cholecystitis. The common hepatic duct measures 3 millimeters. After stabilization, what is the next best step in management? Other than getting a drink of water after reading that long step.
Dr. Blatnick, there's a request to read the response options, please.
Oh, sorry, my fault. A, endoscopic retrograde cholangiopancreatography. B, splenectomy alone. C, splenectomy with cholecystectomy. D, glucocorticoid therapy. Or E, intravenous immunoglobulin therapy, IVIG. Sorry about that. So the correct answer is C, splenectomy with cholecystectomy, which is good. That's what the majority of people answered correctly. A couple little things about A and B. The ducts were noted to be normal on the ultrasound, which is why an ERCP isn't necessarily indicated. Splenectomy alone, we know he's already identified to have mobile gallstones in his gallbladder. And the fact that he has hereditary spherocytosis would certainly put him at risk for developing further stones down the road. So while you're there, I think most people feel that it is appropriate to proceed with cholecystectomy at the same time. Question number 5, a 20-year-old woman, otherwise healthy college student athlete, presents with recurrent nosebleeds, a dark red rash over her lower extremities, and new onset bleeding gums. She denies taking any medications. She's afebrile and vital signs are within normal limits. Laboratory studies are remarkable for platelet count of 46,000. Urinalysis is negative for hematuria, and a urine pregnancy test is also negative. A viral panel is unremarkable for any viremia or abnormalities. Physical examination demonstrates no hepatosplenomegaly. What is the best initial treatment? A, prednisone, 1 milligram per kilogram per day. B, platelet transfusion. C, intravenous immunoglobulin. D, rituximab. Or E, splenectomy. All right. So correct answer is A, prednisone. Good, 57% of everybody got that right. Again, this is what's the best initial treatment. And so the initial treatment in this situation would be prednisone. IVIG is not incorrect, but that's usually reserved for patients who come in with acute bleeding. And in this case, although she describes evidence of bleeding, she's otherwise stable. Her urinalysis is negative. And she is otherwise doing well. So that's where IVIG answer C is not the correct answer. Platelet transfusion, again, also correct in severe hemorrhage. Rituximab for patients that are refractory to steroids. And splenectomy is usually reserved for those patients who fail medical management. Next question. All right, now we're getting to the good stuff. An 80-year-old woman presents with an incarcerated femoral hernia. During surgery, you note small bowel necrosis with significant feculation, perforation identified. What is the appropriate hernia repair for this patient? A, Bassini tissue repair. B, McVeigh tissue repair. C, Lichtenstein repair with synthetic mesh. D, Scholdice tissue repair. Or E, laparoscopic totally extraperitoneal repair. I think this is a key thing, not just for your ABSITE, but for those senior residents going on to take your boards, both the written boards and then especially the oral boards as well. You'll probably be required to know some form of tissue-based repair. And so good, 75% of you guessed McVeigh. McVeigh is a tissue repair, and where that's correct as compared to a Bassini or a Schuldeis, that's the only one that addresses the femoral defect, which is what we're identified with here. Most people agree that using mesh, whether it's in a Lichtenstein open or a totally extraperitoneal repair, is not correct, especially when they talk about significant feculent perforation. I put a couple little pictures here just to remind ourselves of where things are. I think, as I mentioned, if you're getting ready to take your oral boards, you got to know one of these and how to do it. I always recommend people learn and memorize the McVeigh, because not only does it address the femoral hernia, which you may see in this situation, but it also allows you to address the inguinal. So this is a Bassini, where you reconstruct the inguinal floor by opening the transversalis fascia from the internal inguinal ring out of the pubic tubercle. Then you dissect the underlying preperitoneal fat and ultimately kind of close it, overlay in 3 different layers. And on the next slide, we'll kind of see the McVeigh repair, which is similar to the Bassini, except rather than sewing to the inguinal ligament, you sew it down to Cooper's ligament. And then when you get to the femoral of the vein, you do kind of what everybody talks about as that transition stitch, where you go from Cooper's up to inguinal ligament so you don't compress the iliac vein. And that's what allows you to address femoral hernias. All right, let's move on. Question number 7. A 60-year-old man presents to the office for bilateral reducible inguinal hernias. Both trouble him, particularly when he's standing for prolonged periods of time. His surgical history is significant for an open prostatectomy 2 years ago. What is the most appropriate initial approach for this patient's bilateral hernias? A, bilateral Lichtenstein tension-free mesh repairs. B, robotic transabdominal bilateral preperitoneal tap repair. C, bilateral Schuldeis repairs. Or D, laparoscopic totally extraperitoneal bilateral repairs. So the correct answer is A, bilateral Lichtenstein tension-free repair. So mix of things along the way here. So let's talk about this a little bit more. I think in general, most people, especially on an exam situation, would answer, if somebody's had a previous prostatectomy, that doing an open style repair is probably most appropriate. And so that's where the stem here kind of goes to bilateral Lichtenstein tension-free repairs. That being said, there are certainly some of us that will do these repairs minimally invasively. It is certainly more complicated. There is definitely a higher risk for injury to the bladder due to increased scarring, especially in the medial aspect of where things are. If it were me, I would do it in a transabdominal approach, just because you have some more flexibility due to the increased scarring as opposed to a totally extraperitoneal approach. But again, in this situation for an exam, and I would say the same thing if you're taking your boards, in somebody who has not had an open repair before, there's nothing wrong with doing an open inguinal hernia repair, especially in somebody who's had a prostatectomy. So somebody just asked real quick before I started this one, what plane does the urologist enter with an open prostatectomy? So they still, in general, will drop the bladder down and get into the space of Retzius a lot of times. So that inferior portion where you drop the bladder down off of Cooper's and pubic symphysis to get the inferior overlap, that's key there medially, is really, really scarred down there. So prostatectomy, certainly cystectomy. I think for me, that's one of the true absolute contraindication to a minimally invasive inguinal hernia repair is a cystectomy. But in this situation, prostatectomy, open repair, especially if that open plane hasn't been violated. All right, let's move on. A 58-year-old man is referred to your clinic for evaluation of a recurrent right inguinal hernia. The hernia has been enlarging and is now causing him daily discomfort that prevents him from working. His surgical history includes a right totally extraperitoneal inguinal hernia repair and an open appendectomy. On examination, you appreciate a reducible right inguinal hernia but find no evidence of left inguinal hernia. Which management approach is most appropriate for this patient? A, reevaluation of symptoms in 6 months. B, laparoscopic totally extraperitoneal right inguinal hernia repair with mesh. C, laparoscopic transabdominal right inguinal hernia repair with mesh. D, open right inguinal hernia repair without mesh. E, open right inguinal hernia repair with mesh. Good. E is what most people picked. So again, open right inguinal hernia repair. They give you very clear things. They diagnosed a hernia. He's got a noticeable bulge. They also talked that he had a previous TEP repair in the past and an open appendectomy, which makes his intra-abdominal space certainly more complicated along the way. The general consensus here is if somebody has failed a minimally invasive repair, you do open. If somebody's failed open, you go minimally invasively. When you get the more complex one where patients have failed both, which we certainly see, that gets a lot more challenging and ultimately getting more information as to kind of why it's failed. But in general, failed open, go lap, failed lap, go open, and then move on from there. So question 7, somebody asked about minimally invasive prostatectomies. Yes, same thing. It's not quite a scar, but it's certainly still scarred in that inferior area because they open that space up along the way. So I would say yes, if it's a minimally invasive prostatectomy, or if they don't specify, same thing, I would just go open, especially if that plane hasn't been dilated. Question 9, a 60-year-old male with a known history of diverticulosis has a CT-guided percutaneous drain placed for a 4-centimeter paracolonic abscess several days ago. He is currently afebrile with stable vital signs, tolerating a diet, having bowel movements, and without any complaints. Originally, the drain contents were purulent, and today in the office, you notice a small amount, about 50 cc's per day, of enteric contents. Which of the following should be the next course of action? A, additional drain cultures will need to be sent. B, optimize nutrition and watchful waiting. C, obtain another CT scan. D, start additional antibiotics. E, make the patient NPO and start TPN. The correct answer is B, optimize nutrition and watchful waiting. So about half of you, or a good number of you, picked additional CT scan. I think the big thing here that they try to make a point about is the patient's stable. He's got stable vital signs, he's tolerating a diet, he's having bowel movements, he doesn't have any complaints, his drain changed. So in all likelihood, the diverticulum that had perforated just formed a small perforation. And in general, most of these are gonna heal up with just time and watchful waiting, especially when they tell you it's a small volume. If he was unstable, worsening pain, anything goofy like that, then yes, I think getting additional CT scan makes sense and kind of figuring out what's going on from there. All right, next question. 53-year-old man presents to the emergency department with shortness of breath. He's a lifelong smoker. His past medical history is significant for obesity, COPD, and hypertension, treated with a daily inhaled corticosteroids and amlodipine, and his only prior surgery was open cholecystectomy at age 35. Upon examination with the patient seen on the exam table, you notice a large fusiform midline bulge above the patient's umbilicus. The patient states the bulge has been present for the past several years and is slowly enlarging. Upon supine examination, the abdomen is soft and non-tender, and you're able to place 3 finger breaths in the midline sulcus bordered by the patient's abdominal muscles without any obvious defects. What is the next best step in management of this patient? A, no further intervention. B, abdominal ultrasound. C, CT abdomen with IV and PO contrast. D, anterior component separation with mesh. E, laparoscopic hernia repair with mesh. Sounds like my clinic, probably tomorrow. So the correct answer is A, no further intervention. Good. The vast majority of you got that right. So this is diastasis. It's pretty consistent. Usually the patients will come in either on their own accord or sometimes sent in by PCP with this bulge that they say, it looks fine, but when I do a sit up or get out of bed, that's the common thing people notice it, that they get this round kind of football shaped bulge in their upper abdomen. Reassurance is certainly the right answer, especially in this patient who's a lifelong smoker, COPD, corticosteroids, obesity. Stay away from operating on this gentleman. All right, question number 11. A 52-year-old man presents with localized left-sided abdominal pain. He has had the pain intermittently for several months. He denies any nausea or changes in bowel movements. A screening colonoscopy 2 years ago was normal. He's never had any surgeries. His primary care physician ordered a CT scan, which showed a small hernia containing fat just lateral to the rectus abdominis, and he presents to the surgery clinic for evaluation. No bulge is noted at the area of pain. What is the diagnosis? A superior lumbar hernia, B, an inferior petit lumbar hernia, C, Spigelian hernia, or D, obturator hernia. This should be a gimme, guys. Correct, 98%, pretty good. There's 3 of you that we'll have to track down, but the correct answer here is Spigelian hernia. Everybody knows where those are. They usually occur right at the border of the linea semilunaris and the arcuate line. The reason why they can be difficult to palpate is usually the external oblique fascia is still intact. So as you feel it, you don't actually feel a defect through there, but they can certainly have things here. This is an image that I just wanted to put in that kind of shows where those lumbar hernias are. We hear about them. We'll occasionally see them, but those are where the 2 areas where those posterior or lumbar hernias can kind of form, both in the inferior triangle and the superior triangle there. All right, we've got time for 1 or 2 more. So question 12, a 57-year-old female with a past medical history significant for obesity, smoking, rectal cancer, and APR with permanent end colostomy 5 years ago presents to the emergency department with gradually worsening perineal discomfort that she notices most when standing or sitting. She also reports symptoms of stress incontinence for the past 2 years. On examination, a soft bulge is palpated at the posterior aspect of the peritoneum. There's no cervical prolapse, but bulging of the vaginal wall is noted with bimanual examination. The best management of this patient is A, referral for pessary fitting, B, hernia repair with mesh, C, sacrocolpoplexy, or D, manual reduce the bulge and follow up in clinic. The correct answer is B here, hernia repair with mesh. So answers are kind of all over the board. So a few things here. This is a difficult situation. So this is a perineal hernia that can occur after abdominal perineal resections. And these are really, really difficult to treat. The other scenario similar to this that we run into is people who've had pelvic resections of pubic rami and things for cancer. And essentially what happens is you take the floor off of your building. And so your entire pelvic floor in these different situations can be disrupted. And so people can get herniation that's down there. And what's hard is repairing these is really difficult because you don't have a great inferior border to lay your mesh in. But ultimately you can do that. They kind of give you all the points here about what's going on. You know, pessary is good if you're just kind of dealing with vaginal prolapse, but that's not really what's going on here. Sacrocolpoplexy, again, won't necessarily address all the issues of a true herniation down in the pelvis. Tough problem. Question 13, a 65-year-old male with a history of a VP shunt and gastrotomy tube from previous traumatic injury and a small umbilical hernia with a BMI of 50 and progressive chronic kidney disease has been advised to plan for hemodialysis within the next year. He would like to consider peritoneal dialysis, which it would allow him to perform his dialysis at home and would not interfere as much with his lifestyle. A week before his planned PD catheter insertion, he presents to the emergency room with lower abdominal pain and fever. He's diagnosed with diverticulitis and a pericolonic abscess, for which he's now on systemic antibiotics. Which of his medical surgical conditions is a contraindication to peritoneal dialysis catheter placement? A, active diverticulitis with abscess, B, presence of a VP shunt, C, presence of a gastrotomy tube, D, umbilical hernia, E, obesity. So the correct answers here is A, active diverticulitis with abscess, and good, 80% of you got that right. VP shunt, believe it or not, is not a true contraindication in a lot of places for peritoneal dialysis. nor is an umbilical hernia. The one thing we a lot of times fix is inguinal hernia. So if we do have concomitantly identified inguinal hernias, we'll usually fix those because they can trap a lot of the dialysase in their inguinal hernias. Umbilical is not quite as critical, but certainly active diverticulitis in this scenario is the true contraindication. We're at 7. You want to do one more, or you want to?
Yeah, we've got time for one more.
All right, so let's wrap it up here. We have a 67-year-old male with end-stage kidney disease who underwent uneventful laparoscopic placement of a peritoneal dialysis catheter. 8 days later, the catheter occluded with no outflow. The patient has normal vital signs and is in no distress. The most appropriate next step is A, schedule for urgent laparoscopy, B, admit for watchful conservative management, C, discontinue peritoneal dialysis and start hemodialysis, D, exploration of the subcutaneous tunnel, E, forceful irrigation with saline. Again, remember that next step part of the question. Good. Correct answer here is forceful irrigation with saline. There's a lot of reasons why peritoneal dialysis catheters can stop working. It can either be stuck in the omentum, it can get occluded, it can be tweaked, it can also be flipped around. Constipation is another big one our nephrologists make a big deal about. So forceful irrigation with saline is kind of the most appropriate next step. I would say from there, KUB is usually performed a lot of times by their nephrologist to diagnose these non-functioning catheters before they ever make it to us, to make sure it's not flipped up or around or anything like that. If that doesn't work, then a lot of times we'll reposition them or evaluate them with laparoscopy. But next step, forceful irrigation with saline.
Dr. Blacknick, thank you so much for that excellent review of general abdomen, hernia, and spleen. And thanks for sharing your tips and expertise with us.
My pleasure. Thanks for having me.
Our next panelist is Dr. Amber Traugott, another good friend and colleague at the Ohio State University, a colorectal surgeon and master educator. Dr. Traugott will be leading us through our next section on colorectal and anal disease. Welcome, Dr. Traugott.
Thanks, Dr. Awad. I'm happy to be here again. So why don't we launch into the first question? So a 62-year-old woman with a recent history of bleeding per rectum presents to your clinic. She had a colonoscopy 1 week ago. The gastroenterologist identified a 2.6 centimeter rectal mass, 4 centimeters above the dentate line. Biopsy results confirmed the presence of carcinoid tumor. The woman denies any family history of colon cancer or personal history of smoking or alcohol. What is your next step in the management of this patient? A, somatostatin, B, chemotherapy, C, chemoradiation, D, transanal excision, or E, proctectomy with mesorectal excision. All right, so let's talk about this for a little bit. So the correct answer here is proctectomy with mesorectal excision. And the key points that you're gonna see in this stem really are regarding the size of this mass and the type of tumor that it is. So with carcinoid tumors, you need to be aware of the recommendations for management based on size. So this is a 2.6 centimeter carcinoid. And so it's got a pretty high risk of lymph node metastasis. And so in this case, you want to do a radical excision where you're getting the mesorectal lymph nodes. And so that's why E is the correct answer. Many of you chose D. In fact, the majority of you did. So transanal excision is an option for smaller carcinoid tumors in the rectum. And we'll get into that a little bit, perhaps in the next question. So here we have a 61-year-old man who's found to have a 0.7 centimeter rectal carcinoid, approximately 5 centimeters from the dentate line. A complete workup does not demonstrate any lymphadenopathy or metastatic lesions. What is the best next step in management? A, transanal excision, B, proctectomy, C, systemic chemotherapy, D, neoadjuvant chemotherapy and radiation, or E, observation of the lesion and repeat colonoscopy in 3 to 6 months. So good, you all learned from the first question already. So the point here is that if the tumor, if it's a carcinoid that's less than 1 centimeter in diameter and there's no evidence of any metastatic disease or lymph node involvement, transanal excision is adequate because the risk of lymph node involvement is going to be low. How far from the dentate line to be able to do transanal excision is a question in the chat. So that kind of depends on what techniques you're familiar with. For a standard transanal excision, basically whatever you can reach is probably somewhere going to be around 5 to 6 centimeters. But using TAMIS or other advanced endoscopic techniques, one can get up to 10 to 15 centimeters, depending on whether it's an anterior or posterior lesion. All right, next question is a 61-year-old HIV positive woman presents with intermittent rectal bleeding, pain, and pruritus. On examination, you note a small intraanal ulcer with exophytic margins just distal to the dentate line. Biopsies later confirm a squamous cell cancer. Pelvic MRI shows a 3 centimeter lesion and concern for an enlarged lymph node. What is the next diagnostic modality for workup? A, transvaginal ultrasound. B, CT of the chest and abdomen. C, FDG PET CT. D, colonoscopy for synchronous lesions. Or E, no further tests, proceed with chemoradiation. Okay, so let's talk about this one too. This is another example of the next diagnostic modality. Most of you chose B, CT of the chest and abdomen. And indeed, in a patient with a newly diagnosed squamous cell cancer of the anal canal, that would be an appropriate step for a standard staging evaluation. I think the important thing to focus on in this particular stem is the concern for an enlarged lymph node on that pelvic MRI. So in situations where you're staging an anal squamous cell carcinoma and there's a questionable lesion, PET CT would be the preferred modality to evaluate whether that represents a metastatic lesion or not. And so while yes, this patient would have a CT of the chest and abdomen, most likely as part of their workup, you particularly are going to want to get a PET scan for this patient to evaluate the lymph node that came to your attention on the MRI. Next question is a 66-year-old female, is 2 years status post chemoradiation per the NIGRA protocol for squamous cell carcinoma of the anus. The tumor completely regressed and she had been doing well until the past month when she noticed increased blood on the toilet paper following a bowel movement. A small mass was noted on digital exam and biopsy confirmed a recurrent squamous cell carcinoma. Complete staging workup has revealed no evidence of nodal disease or distant metastasis. What is the optimal treatment for this patient? A, abdominal perineal resection. B, repeat chemoradiation per NIGRA protocol. C, radiation therapy. D, chemotherapy alone. Or E, transanal excision. So the correct answer is A, APR, which 64% of you got correct. So many of you also chose repeat chemoradiation per NIGRA protocol. And in these situations, we don't re-radiate a patient who has recurrent anal squamous cell carcinoma unless there's some contraindication for surgery. And usually 2 years out would be too soon to consider that. So that would not be standard therapy. We perform salvage APR for patients who have persistent or recurrent disease after standard NIGRA protocol. transanal excision is not an appropriate option for this patient, as outcomes are significantly better, and a patient in a radiated field is not going to have a good healing outcome from a transanal excision. All right, number 5 is a 50-year-old woman presents to your clinic for evaluation of perianal pain. She notes that the pain is sharp, like being cut with glass, worse with defecation, and associated with spotting of blood on wiping with toilet paper. A recent screening colonoscopy showed internal hemorrhoids. No external hemorrhoids are visible on exam, and she poorly tolerates a digital rectal exam because of exquisite pain in the posterior position. If her condition fails to improve with dietary modifications and appropriate fiber intake, what would be your next step in management? A, hemorrhoidectomy, B, hemorrhoidal artery ligation, C, lateral internal sphincterotomy, D, Botox injection, or E, topical calcium channel blocker. Okay, so the correct answer is E, topical calcium channel blocker. So what's important to recognize in this particular stem is that the symptoms that are being described and the exam findings are most consistent with a posterior midline anal fissure. And although the patient has internal hemorrhoids, they typically don't cause that sort of pain or that sort of exam finding. So any hemorrhoid intervention is going to be inappropriate for those of you who chose A, hemorrhoidectomy. In terms of which of the 3 choices you would choose for initial management of an anal fissure after dietary modifications, we tend to start with the least invasive and move to most invasive. And so in most cases, we would offer patients a trial of a topical smooth muscle relaxant like calcium channel blocker or topical nitroglycerin before taking them to surgery for a lateral internal sphincterotomy. Next question is a 47-year-old man with a history of Crohn's disease who presents to the office for a routine checkup. He's been taking infliximab and azathioprine for several years without any recent flares. He's maintaining a healthy weight and he denies fever, abdominal pain, or changes in bowel patterns. During the examination, you notice a perianal fistula with increased granulation tissue, but no palpable fluid collection or tenderness. He admits there's been more mucoid and blood discharge for a couple of months, but it does not bother him. He has dealt with it for so many years. What is the best next step? A, prescribe a 7-day course of oral antibiotics. B, start 40 milligrams of prednisone daily and taper when symptoms improve. C, schedule for examination under anesthesia and colonoscopy. D, perform a biopsy and curettage of the fistula in the office. Or E, refer to gastroenterology for modulation of chronic medications. So C, many of you chose C, scheduled for examination under anesthesia and colonoscopy. The correct answer is D, perform a biopsy and curettage of the fistula in the office. So the key points that you want to pick out from this particular scenario are that this patient has long-standing inflammatory disease with stable disease control by his symptoms. And then he has a new finding. He does no evidence of infection on your exam. He just has this draining sinus tract. And in this case, it's really important to consider that you must rule out a malignancy due to his chronic inflammatory disorder, which is something that you can do really by performing a biopsy in the office as long as he's not having tenderness there. But if the patient's not able to tolerate that, then you could take the patient for an EUA, and you might consider a colonoscopy if they are due for that for disease surveillance. But in the absence of any symptoms to suggest any change in his inflammatory pattern, that's not necessary if there's no other indication at this time. So next question is an 18-year-old man presents with appendicitis of 2 days duration. He's taken to the operating room for laparoscopic appendectomy, and the appendix is found to be inflamed at the base with no thickening of the cecal wall. While you manipulate the appendix, it breaks off at the base. What do you do to manage the situation? A, remove the appendix and leave a drain. B, attempt laparoscopic suture ligation of the base. C, perform a stapled resection of the appendiceal base at the soft cecal wall. D, perform a laparoscopic ileocecectomy. Or E, convert to an open appendectomy with closure of the base. So the correct answer is C, which most of you got. Perform a stapled resection of the appendiceal base at the soft cecal wall. The next most common answer for this was perform a laparoscopic ileocecectomy. And as long as the cecum's normal, you don't need to go to that sort of length and perform that degree of surgery. You really just want to make sure that you've performed an appropriate resection and you've not left an open appendiceal stump. 8 is a 55-year-old woman who is treated for C. diff colitis with oral metronidazole for 10 days. A week after completing the course of antibiotics, she still has symptoms. A repeat C. diff stool toxin study is positive. What is the appropriate management? A, 10-day course of oral vancomycin. B, combination pulse tapered oral vancomycin and fidaxomicin. C, another 10-day course of oral metronidazole. D, fecal transplant. Or E, a 7-day course of oral rifaximin. So the correct answer is A, a 10-day course of oral vancomycin. And really just the key here is that you need to kind of know the guidelines for your algorithm for treatment of recurrent C. diff. So if they initially have received oral metronidazole, then you want to treat with oral vancomycin as a single agent first. But then if they were initially treated with vancomycin, then you might consider a pulse tapered regimen of fidaxomicin or oral vancomycin. So those are, you would consider option B if they've already failed oral vancomycin as a single agent. Next question is a 30-year-old man who presents for abdominal colectomy after being diagnosed with familial adenomatous polyposis. He is otherwise asymptomatic. Intraoperatively, the initial abdominal exploration is negative for any metastasis. However, while running the bowel, you notice a fleshy circumscribed 4-centimeter mass in the mesentery with desmoplastic reaction. What is the best operative plan? A, complete the abdominal colectomy. B, excise the mass with margins and complete the abdominal colectomy. C, abort the abdominal colectomy, excise the mass, and send frozen section for negative margins. D, complete the abdominal colectomy, perform core needle biopsy of the mass. Or E, complete the abdominal colectomy with segmental small bowel resection, including the mass in the mesentery. So the correct answer is D, complete the abdominal colectomy and perform core needle biopsy of the mass. So it's important to recognize that it most likely represents a small bowel mesenteric desmoid. And generally speaking, these are pretty indolent tumors that grow very slowly. And they tend to have a very high recurrence rate after resection. And it can be very morbid to resect these because you may end up having to take a fair amount of small bowel with them, and to the point where you may end up compromising the patient's nutrition. And so in general, we tend to manage desmoids non-operatively unless they are causing some symptoms or posing some sort of imminent risk to adjacent structures. So you want to confirm that it is indeed a desmoid tumor and not a metastasis from an occult cancer. And so that's why you would perform the core needle biopsy. But then you would continue with your colectomy for the FAP. There's a question in the chat about guidelines for C. diff colitis. Is it not recommended to start with vancomycin? That's true in many areas, but that is somewhat guided by local resistance rates to metronidazole. And so there are places where one might, it might be acceptable to give oral metronidazole first.
Sorry.
All right, well, the next question, hopefully you'll all get right. So you're called to the ED to evaluate a 70-year-old man who presents with a 2-day history of abdominal pain. He has a mild leukocytosis and a slightly elevated lactic acid. CT shows pneumatosis in the cecum. Examination shows mild tenderness in the right lower quadrant. What is the most appropriate next step in management? A, operating room for exploratory laparotomy. B, bowel rest and antibiotics. C, diagnostic laparoscopy. D, admission and immediate colonoscopy. Or E, discharge and outpatient colonoscopy. So the correct answer is B, bowel rest and antibiotics, which most of you got correct. Those of you who chose A, operating room for exploratory laparotomy, it's important for you to kind of note the stability of this patient and the lack of acute findings on his exam. This is most likely a patient who has ischemic colitis, and this may respond to bowel rest and antibiotics as is standard. Certainly you would perform serial exams and monitor the patient clinically for any sign of deterioration, in which case A would be then the correct answer. Next question, a 55-year-old man is recovering from a right hemicolectomy for colon cancer that was identified on screening colonoscopy. Pathologic exam demonstrates a 3-centimeter mass invading through the muscularis propria with negative margins. The mass is well differentiated without evidence of vascular invasion, with 0 of 10 negative lymph nodes. What is the next best step in management? A, close follow-up with CT of the chest, abdomen, and pelvis every 3 months for 2 years. B, colonoscopy every 6 months for 3 years. C, chemotherapy. D, chemotherapy and radiation. E, radiation. So the correct answer is C, chemotherapy. And really what you need to understand is the indications for chemotherapy for colon cancer. So in this case, this is a patient who has a stage 2 cancer because you know that it's a T3 lesion. And while the stem does not give you any tumor specific characteristics that are high risk, the one characteristic it gives you is that there was an inadequate lymph node harvest. So 12 lymph nodes are required to adequately stage a cancer to determine whether it's stage 3 or not. And so having an inadequate lymph node harvest, even if they're all negative, is a risk factor that makes a stage 2 cancer high risk, and for which you would consider chemotherapy. And of course, that would be a discussion with the patient about the risks and benefits in conjunction with their oncologist, but that is considered a risk factor. So you want to make sure that you know risk factors for stage 2 lesions that might be an indication for chemotherapy, and that would be perforated tumors, obstructed tumors, poorly differentiated tumors, lymphovascular or invasion, or if your margin status is poor. So those are considerations, not necessarily mandatory, but warrants a discussion. Next question, a 50-year-old man presents to your clinic after a screening colonoscopy. He has no personal or family history of colorectal cancer or any risk factors. A single 3-centimeter sessile polyp with high-grade dysplasia was completely resected piecemeal from the descending colon. He was content when he knew that it was completely resected. He asks about follow-up. What would you advise? A, repeat colonoscopy within 6 months. B, repeat colonoscopy at 1 year. C, repeat colonoscopy at 3 years. D, repeat colonoscopy at 5 years. Or E, repeat colonoscopy at 10 years. So the correct answer is A, repeat colonoscopy within 6 months, which about half of you got. So the key factors here are that this was resected piecemeal and that it has high-grade dysplasia. And so those two factors would push you to repeat the colonoscopy within 6 months just because of those risk factors. If there weren't risk factors associated with the piecemeal resection, such as if there weren't high-grade dysplasia present and the margins were clear, then 1 year would be the appropriate answer. Next question, a 76-year-old woman presents to the ED with 3 days of progressive abdominal pain, nausea and vomiting, and obstipation. Abdominal exam demonstrates significant abdominal distension, but no evidence of peritonitis. CT demonstrates significant distension of the entire small bowel and proximal colon up to the mid-transverse colon. The remainder of the colon and rectum is decompressed. Which of the following is the most likely explanation for this woman's presentation? A, volvulus of the large intestine around a fixed axis. B, distal obstruction with an incompetent IC valve. C, diffuse enterocolitis. D, colonic pseudoobstruction. Or E, primary GI dysmotility. So the correct answer is B, distal obstruction with an incompetent IC valve. And so the next most common answer that some of you selected was option A, volvulus of the large intestine around a fixed axis. And I think what's important for you to note is that when that happens, that's a closed loop obstruction. And the description that's being given here is not of a closed loop obstruction. And the point of distal obstruction is not an area that is typically a site of volvulus at the mid-transverse colon. Colonic volvulus tends to happen at the sigmoid or at the cecum more commonly. And so it's important to note that this is most likely due to a cancer or some other cause of focal obstruction. And with an incompetent IC valve, then the small bowel will become dilated. If the IC valve were competent, that would create a closed loop obstruction between the IC valve and the point of distal obstruction, and that can precipitate a surgical emergency or a perforation of the cecum most commonly. Next question is a 75-year-old woman with multiple medical problems, including poorly controlled diabetes, hypertension, and ischemic heart disease, who was brought to the ED for severe abdominal pain she's had for 1 day. Clinical exam reveals generalized peritonitis. After IV fluids and antibiotics are started, she's taken for a laparotomy. She's found to have fecal peritonitis secondary to a perforated distal sigmoid cancer and a redundant sigmoid. You decide to resect the tumor and fashion a stoma. Which of the following options would be ideal? A, sigmoid end colostomy. B, a descending colon end colostomy. C, a transverse colon loop colostomy. D, a cecal colostomy. Or E, a loop ileostomy. So B, a descending colon end colostomy is the correct answer. So in this situation, in a patient who's high risk for any future surgery, and you know that the patient likely has a sigmoid cancer, you would do your best to try to perform an oncologic resection at the time of the perforation, even though that may be difficult. And so in order to do that, you would have to take the inferior mesenteric artery high in order to get lymph nodes. That would then mandate that you'd have to make the colostomy from the descending colon. And it's unlikely that this patient is going to be reversed. So you would not plan to make any sort of temporary ostomy in this situation.
And our last question.
Okay, our last question is a 55-year-old man with stricturing Crohn's disease requiring 4 previous resections who presents to the ED with abdominal pain, nausea, and vomiting for 3 days. CT scan shows diffuse small bowel dilation with a transition point in the right lower quadrant. You take the patient to the OR and find a 7-centimeter fibrotic stricture in the ileum, 10 centimeters from an ileocolic anastomosis. He has 100 centimeters of small bowel remaining. What is the appropriate management of the small bowel stricture? A, Finney stricturoplasty, B, Heineken-Mikulicz stricturoplasty, C, Michelossi stricturoplasty, D, internal bypass, or E, small bowel resection with end ileostomy. So the correct answer is B, Heineken-Mikulicz stricturoplasty. And it's important for the ABSITE to be familiar with these different stricturoplasties and the situations in which they can be used. Heineken-Mikulicz can be used for shorter strictures. So in general, up to 10 centimeters, you might be able to do this. And this is just where you open the stricture longitudinally and close it transversely. Finney stricturoplasty can be used for kind of intermediate length strictures, around 10 to 20 centimeters in length. That's essentially like performing a little side-to-side anastomosis through the stricture. Michelossi is a isoperistaltic side-to-side anastomosis or stricturoplasty, and that's for very long strictures. But the point here is that in a patient where they have already a marginal amount of small bowel left, you want to try to do something to preserve their small bowel if there's not a finding that absolutely mandates a resection. And so that's why you want to perform a strictureplasty in this patient.
Dr. Traugott, thank you again so much for joining us this year and a tremendous overview of the colorectal and anal questions. Really appreciate it.
Thanks for having me.
Thank you. And while we're bringing up our next panelist, we're just a reminder, in the chat box, you'll see a link for the survey. We really appreciate y'all's feedback that we take in and make adjustments to every year. So please take a moment to fill out that survey. Now, it is my distinct pleasure to introduce our last panelist, who will lead us through small intestine biliary disease and flexible endoscopy, Dr. Timothy Reeland at Brooke Army Medical Center, a tremendous colleague and who many think of as a surgeon, one of the smartest guys I know, and really a pleasure to have on the webinar with us today. Dr. Reeland, thank you again for being here.
Thank you very much, Dr. Awad. I'll try to keep it lively. I'm sure people are getting tired at this point, but we'll keep going. Got some good questions here. So first question, a 55-year-old female was involved in an MBC. She's now in the ICU, day 4. She has a TBI, multiple rib fractures, closed femur fracture. She develops a fever, leukocytosis, and diffuse lung infiltrates. How should she be evaluated? A, ventilator waveform interpretation. B, quantitative BAL of the lower airway. C, capnography analysis of ventilation. D, high resolution CT of the chest. Or E, cardiac serologic markers. All right, so the correct answer is B, which the majority did get. Some people said D, which, you know, again, in real life, would you get a CT on this patient? Potentially, but I think what they're driving at here is you should suspect pneumonia in this patient. And the only answer that really makes sense for that is a BAL. A CT you could diagnose, but BAL makes a little more sense. BAL is indicated for non-resolving pneumonias, diffuse lung infiltrates like this patient, suspected alveolar hemorrhage, quantitative cultures for ventilator-associated pneumonia, and then infiltrates in an immunocompromised host. So again, it is some of this, we'll go over this with a lot of these questions. Don't overthink it. The test taking thing here is just sort of go with the simple answer, not always what you would do in real life, but what the test answer would be, which is going to actually give you a diagnosis. Whereas a chest CT might just show you some infiltrate, but you wouldn't be able to actually diagnose the pneumonia and get a culture. So do the test that gives you the best answer. All right, next one, 57-year-old smoker is referred to you with a biopsy proving diagnosis of a adenocarcinoma in the right middle lobe found on a CT. PET scan is done and shows an enlarged lymph node that's hot, and it's in the region of the right pulmonary ligament. Case is presented and they want to get a biopsy basically. So what is the best method to access a node at the pulmonary ligament? A, mediastinoscopy, B, EUS guided biopsy, C, EBUS guided biopsy or endobronchial ultrasound, D, Chamberlain procedure, or E, CT guided biopsy. And this is really kind of just an anatomy question and understanding how you get to the different nodes in the mediastinum. All right, so the correct answer is B, which is an EUS guided biopsy. Okay, we're kind of all over the place on this one. I added a picture, if we can go to the next slide, because I had a feeling this one would be tough. There's always like 1 or 2 lung cancer questions on the ABSITE, and they always drove me crazy because as general surgeons, we don't do a lot of lung cancer. So, it's one of those things where you can either try to study about lung cancer or just accept that you're going to miss one question here. I think you have to make that decision for yourself, but some basic anatomy here is just understanding where these lymph nodes are, right? The inferior pulmonary ligament is way down here. The only way you're getting to that is by the EUS, right? So the lower mediastinal nodes, you have to get to it through the esophagus. You can't get to it through the bronchus. And a Chamberlain procedure is to look here at these nodes in the PA window. So EBUS is for the high nodes, the aortic pulmonary window nodes, that's the Chamberlain procedure, or mediastinoscopy can reach those as well. But those low mediastinal nodes, if you think about, most of you have probably seen the inferior pulmonary ligament in a thoracotomy. It's down low. It's well below the carina. So the only way you can get those is endoscopic ultrasound via the esophagus. So that's really just an anatomy question, that one. All right, 52-year-old male presents to the emergency department with right lower quadrant tenderness after undergoing a colonoscopy during which a polypectomy was performed. He's mildly hypertensive and febrile, but other vital signs are normal. CT demonstrates inflammation near the right colon as well as pericolonic fluid, but no evidence of free air. What is the next appropriate step in management? Make the patient NPO and start antibiotics, repeat colonoscopy with endoscopic clipping, image-guided drain placement, exploratory laparotomy with primary repair, or right colectomy with end ileostomy. So somebody asked, why not CT guided for the last one? I think that if the node is really big, potentially you could get to it with CT, but for smaller nodes, CT guided by IR, but for smaller nodes, an EBUS guided biopsy is pretty typical, or I'm sorry, not EBUS, EUS guided biopsy is pretty typical. I don't think that CT is impossible there, but I just think an EUS is an easier biopsy and a better answer. All right, so for this one, most people got it right. So this is what some people call post-polypectomy syndrome. And, really, I think of this like diverticulitis, right? So if you have a patient who's stable, you have a little bit of bubbles of air around the colon, some stranding, but no free air, they're not peritonitic, they're not hemodynamically unstable, then, just treat them like you would diverticulitis, treat them, make them NPO, put them on broad spectrum antibiotics. The vast majority will get better with that. So that's about it for that one. All right, next question. 50-year-old man is undergoing an initial screening colonoscopy, has a long tortuous colon requiring position changes and abdominal compression to pass the scope. After passing through a long straight portion with little haustration followed by a complex flexure, a wider lumen is encountered with triangular folds and a long segment of view. At this point, the tip of the scope is most likely into which part of the colon: the distal sigmoid colon, the ascending colon, the transverse colon, the descending colon, or the cecum. Again, this is kind of an anatomy question. If you've done colonoscopies, this is probably pretty straightforward. If not, it may be difficult. So transverse colon, let's see the results. Good. So almost everybody got that one. Again, the people who didn't probably haven't done colonoscopies. It's pretty easy to tell when you're in the transverse colon because it's shaped like a triangle. The cecum has this classic Mercedes sign where the tinea come together at the end. The rectum is known for kind of the prominent veins in the wall, has this very characteristic appearance. And then the hepatic flexure, usually you have a long segment with kind of a blue hue from the surface of the liver touching the colon. So those are kind of the landmarks you should know in a colonoscopy, but that triangular appearance is very characteristic of the transverse colon. All right, next one. You were rounding on a patient who is 2 days post-op from lysis of adhesions and small bowel obstruction, or for a small bowel obstruction. She's complaining of increased abdominal pain and nausea. Vital signs are a temperature of 38.5, pulse is 120, blood pressure is 110/70, oxygen saturation 95 on a liter of oxygen. On exam, she has diffuse tenderness and rigidity. Laboratory studies are notable for increased white blood cell count of 15,000. She was 13,000 the day before. In addition to IV fluid and antibiotics, what is the next best step in management? Obtain an upper GI. B, obtain plain abdominal radiograph. C, obtain a CT with IV contrast. D, proceed to the OR for re-exploration. E, continue to observe with serial abdominal exams. All right, and so the correct answer here is proceed back to the OR for re-exploration. So this is just really a don't overthink it and be conservative on the test, right? And really in real life, if you saw a patient who had peritonitis 2 days out from a lysis of adhesions, you should be going back to the operating room. You're thinking leak 10 times out of 10 here. So I think this is just, don't overthink it. Some people said obtain a CT. In real life, you might drag your feet and get a CT scan, but you're probably just trying to convince yourself that you didn't cause a leak when you did. A patient who's post-op day 2 on a test with a rigid abdomen, just go back to the operating room. Don't overthink it. All right, next one. 81-year-old male presents with increasing fatigue as well as difficulty walking due to feeling unbalanced and having numbness on his hands and feet for the past 2 months. He has a history of morbid obesity and underwent a Roux-en-Y gastric bypass 40 years ago. He has had many years of intermittent abdominal cramps and loose, watery stools. He also reports that he's becoming increasingly forgetful lately and often forgets to take his medications. How should the patient's diagnosis be established? So A, carbohydrate breath test, B, barium swallow study, C, CT scan of the abdomen and pelvis, D, the diagnosis does not require confirmation, or E, capsule endoscopy. And again, I think it was mentioned earlier, but how exactly that last line, that last question is worded is very important. So how should the patient's diagnosis be established? So they're asking, do you know the diagnosis? And then how is that diagnosis established? So correct answer here is a carbohydrate breath test. So this is a good one to go over. So the diagnosis here is a blind loop, which apparently a lot of people think does not need confirmation, which I'm not exactly sure what to say about that. I think it does require confirmation. And then, on the test, they're asking how should it be diagnosed, and the right answer is there. The confirmatory test is a carbohydrate breath test, which is where essentially you give the patient sort of a labeled carbohydrate that has a labeled carbon in it, and then the bacteria chew it up and then spit out gas in the GI tract that eventually will get into their breath. So you do the breath test. I think it's every 30 or 40 minutes for a couple hours, and that labeled carbon in their breath will go up. And the point here is that he had bariatric surgery in the past, and he has these symptoms that are characteristic of probably a B12 deficiency. He has a numbness, tingling, the feeling of fatigue, which is probably anemia. So you got to kind of put all that together, figure out he has B12 deficiency. Why does he have that? After a Roux-en-Y, because he has a blind loop. How do you confirm that with a carbohydrate breath test? So it's a multi-level question, but I think a fair question. And the correct answer is right there for the confirmatory test. So I'm not sure why you would say it. It doesn't require confirmation. So, all right, next one. 60-year-old morbidly obese male is undergoing an open subtotal colectomy with end ileostomy for an ischemic colon with perforation and massive contamination. He is septic and hypotensive. Because of the inflammation of his mesentery and his body habitus, the distal ileum cannot be mobilized above the skin level for ileostomy creation. What is the most appropriate next step? A, excise subcutaneous fat to bring the skin down to the ileum. B, sequentially score the peritoneum of the mesentery or pie crust to gain length. C, divide the mesentery distally to gain length. D, affix the mature ileostomy at the fascia level. E, perform ileorectal anastomosis. All right, so the correct answer is sequentially score the peritoneum of the mesentery to gain length. I think most of you got that, which is great. The other options are just not good, right? So certainly dividing the mesentery distally is the wrong answer, because if you are going to, score or divide the mesentery, you should do it down low so that the arcade out by the bowel is going to remain intact and perfuse the bowel. Affixing the ostomy to the fascia is a bad idea, because you're going to get stool into the subcutaneous fat and a necrotizing infection. That would be bad. You're not going to perform an anastomosis in this patient. They kind of gave you all the clues to that. So scoring the peritoneum down low, and you can't even divide some of the proximal mesentery, just making sure that you maintain an arcade, which can be difficult in an obese patient to tell exactly where the vessels are, but that's certainly the best option here. All right, next one, a 33-year-old man presents to the emergency room with concern for acute appendicitis. He's taken to for diagnostic laparoscopy, where he's found to have a normal appendix. However, 60 centimeters from the ileocecal valve, a Meckel's diverticulum is appreciated, and there is pan-inflammation of the entire diverticulum. What is the next best step in management? Appendectomy alone, just observe the Meckel's. Segmental resection of the bowel that includes the diverticulum, consider appendectomy. Diverticulectomy, consider appendectomy. No resection, managed with antibiotics, or ileocecectomy. So this one boils down to management of a Meckel's. Are you going to leave it alone? Are you going to just take the diverticulum? Are you going to do a segmental resection or treat with antibiotics? Correct answer here is a segmental resection, which most of you got, 65%. Next most common answer was a diverticulectomy. And the reason I think it's fair enough, right? This is a symptomatic Meckel's diverticulum, so you're going to do something. You're going to resect something. The reason that diverticulectomy alone is wrong is because it says there's pan-inflammation of the entire diverticulum, right? So if it was a thin, long diverticulum and only the tip was inflamed, then a diverticulectomy would be reasonable. But because the whole thing is inflamed, you're going to be stapling or cutting across and closing inflamed bowel, or you're going to be narrowing the bowel if you want to get below the inflammation. So when there's pan inflammation, I think doing a segmental resection is always going to be the right answer. And then don't leave it alone if it's symptomatic. If it was asymptomatic and found incidentally, you could potentially leave it alone. All right, this is a long one. So 72-year-old female presents to the emergency department with a severe abdominal pain for the last 4 hours. She had one episode of coffee ground emesis in the past hour. She has a history of paroxysmal AFib, hypertension, hyperlipidemia, and type 2 diabetes. She's on lisinopril, atorvastatin, and metformin. Vital signs: she's febrile, her heart rate's elevated, her blood pressure is high, Her respiratory rate is normal and she's satting okay. On exam, she's writhing in pain and significant distress. Abdominal exam is noted for only mild abdominal tenderness to palpation and minimal distension. Her labs show a white count of 26 and a lactate of 4.9. CT reveals edematous small bowel, gas in the mesentery, and a lesion in the SMA 6 centimeters distal to the takeoff from the aorta. What is the best definitive management for her condition? A, initiation of broad spectrum antibiotics and bowel rest. B, systemic anticoagulation with heparin. C, administration of intra-arterial papaverin. D, endovascular embolectomy. E, laparotomy with surgical embolectomy. And just quickly, the last, there's a question about the blind loop. Do we increase the length of the roux limb to surgically treat the situation? So yeah, I think it depends. If there's truly a blind limb, like if the little candy cane off the GJ has distended and that's where your blind loop is, then you just resect that. If you have roux stasis, which is a little bit different, but could cause, potentially that bacterial overgrowth, then yes, you might shorten your roux limb. So it depends what you found on your imaging at that point. All right, I think I saw the answers flash. They kind of went away from me, but the correct answer here, laparotomy with embolectomy. Oh, there it is. Okay, good. So most people got this. You have a lot of clues here, right? She has AFib. She's writhing in pain, but not particularly tender, right? So she has pain out of proportion to her tenderness, her lactate's up, and then they give you the CT that it's 6 centimeters from the takeoff. So really, the only real answer here is laparotomy with surgical embolectomy. Endovascular embolectomy, you're going to want to look at the bowel given the findings on the CT scan. One key, this could be chronic, acute on chronic ischemia, but that happens right at the takeoff of the SMA. So the fact that it's a few centimeters off, usually that embolus will get lodged right where the middle colic comes off the SMA. So 6 centimeters is a little far, but anyway, wherever the vessel narrows, that's where the embolus gets lodged. Whereas acute on chronic, it happens right at the takeoff from the aorta. And I think the rest of these are obviously wrong. Most people got this one right. So, all right, next one. A 56-year-old woman undergoes a total colectomy with ileorectal anastomosis for colon cancer. Post-op day 3, she reports abdominal pain despite a PCA, and she has emesis. Her bowel sounds are reduced with abdominal distension without rebound tenderness. Her vital signs and electrolytes are within normal limits. An abdominal radiograph shows uniform distension of the stomach, small bowel, and colon. What is the next best step in management? A, CT scan. B, surgical reexploration. C, NG tube. D, neostigmine. E, erythromycin. So this is kind of the opposite of that one where the lady had a rigid abdomen. You clearly need to go to the operating room. This is conservative management. Yeah, so 90% of you got this. This is an ileus, right? She has dilation all throughout her GI tract. Treat it like an ileus. NG tube, try to avoid narcotics, replace electrolytes, walk a lot, et cetera, but no reason for these other things. Neostigmine is for Ogilvy's. Ogilvy's typically does not have distension of the small bowel. So if you had uniform dilation of the colon, you might give neostigmine, although I would caution, always do a CT scan before you give neostigmine just to make sure there's no distal obstruction. And then I wouldn't re-explore at this point, given her benign exam, et cetera. All right, next one. A 7-year-old man presents with for an upper GI endoscopy for vague dyspeptic symptoms. The patient has a history of subtotal colectomy for FAP. Upper GI reveals a normal stomach and several polyps in the duodenum, 4 in total, with the largest size being 3 millimeters. Biopsy reveals tubular adenoma in all the polyps. One of the polyps in the second portion of the duodenum has severe dysplasia, but is completely resected. The rest of the upper GI endoscopy is unremarkable. Which of the following is most appropriately characterizes the management strategy for this patient? A, repeat endoscopy in a year. B, a Whipple. C, pancreas sparing duodenectomy. D, EGD with endoscopy or with endoscopic ultrasound. Or E, repeat endoscopy in 3 years. I think this might be the toughest question of the group that I had. So we'll see how everybody does. All right, so correct answer is a repeat endoscopy in 3 years. Yeah, kind of all over the place, which I'm not surprised by. So, I mean, this is tough. There are these very specific criteria for FAP polyps and how to surveil them. So we can go to the slide. I made a slide just so we can kind of go over it. But, there are these criteria, and it's based on the number of polyps, the size of the polyps, and then whether they're tubular or villous or tubulovillous, and then how much dysplasia you have, right? So this patient had 4 polyps that were all under 4 millimeters. They were all tubular, but one had severe dysplasia. Now it was completely resected, so it doesn't leave that question of, is there cancer underneath that you're not getting? So, basically the question is, when would you surveil again? Because you've done the surveillance, you've taken out the most suspicious looking polyp. It did have dysplasia, but no invasive cancer. So you're just really, the question here is, when would you do repeat surveillance? And so you have to add up the points here. So this patient got 6 points. They're in the stage 2. And then I think I have one more slide that shows what to do with those numbers. Yeah. So if you have 6 points, you go to 3 years. I mean, I think it's really in the weeds for the ABSITE, to be honest. I think it's a tough question, but just understanding the basics here, that if you have a few polyps that aren't huge and have some dysplasia but can be resected, then you're going to repeat surveillance in a couple of years. You're not going to do a Whipple in this patient. The only patients that you would do surgery for are the ones who have all the points, which means that they have some big polyps with severe dysplasia, and also typically are villous, right? Because the villous polyps you typically can't take out in one piece, just like colorectal, right? If you have a villous polyp that you have to piecemeal out, has high-grade dysplasia, then you would consider trying to resect it. That's where you might think about an EMR or something like that, as opposed to just doing a Whipple right away. Anyway, I think this is a little bit in the weeds, but if you guys want to look at these criteria, they're called the Spiegelman criteria. And if you want to get a 99 on the ABSITE, you might want to look that up. So, all right. A 37-year-old man presents to the ED with intermittent abdominal pain and states that he has not had flatus or a bowel movement in 5 days. He says that his abdomen feels full. He underwent a laparotomy 2 years ago for a splenic laceration. His vital signs are normal. On exam, there are high-pitched bowel sounds with no tenderness to palpation. He is mildly distended with moderate tympany. What is the next best step in management? A, an upright abdominal X-ray. B, exploratory laparotomy. C, NG tube placement. D, laxative therapy. I think this one's pretty straightforward, hopefully. Yeah, A is the right answer. I think A and C. Yeah, I figured A and C would be the two that people would go with. So I think the point here is that you don't know what's going on, right? He might have a sigmoid volvulus or something. So you don't put an NG tube down until you have a diagnosis. So how do you get a diagnosis? Upright X-ray would be the first step. And in real life, you would do the same thing too, right? He hasn't thrown up. So if his stomach's not distended, you might not even put an NG tube down. You probably would. But the bottom line is this is likely a small bowel obstruction from adhesive disease given his previous laparotomy. But you don't actually know that until you get the X-ray. So don't, put the cart before the horse. Just get the upright abdominal X-ray and then place your NG tube. All right, couple more minutes. This is a long one. All right, so you're in the OR. I'm going to shorten this. You're in the OR treating a strangulated ventral hernia. There is a ton of bowel in there. And after you get all the bowel out, 150 centimeters are dead. You take that out. The remainder of the bowel that was in the hernia sac, about 100 centimeters, appears dusky but not necrotic. You cover it, and 15 minutes later, it seems a little better. However, the patient has escalating vasopressor needs and urine output is dropping. What would you do next? A, resect the bowel that was involved and perform an anastomosis. B, leave the abdomen open and re-explore in 24 hours. C, perform an anastomosis without further bowel resection. D, perform an anastomosis, leave the abdomen open, re-explore. Or E, continue to observe in the OR until it delineates. All right, B is the correct answer. Good. 98% of you got that. Let's go on to the next one. So good. Yeah, just give that bowel some time to delineate before you take out all his bowel and he has shortcut. All right, next one. A 65-year-old woman presents the emergency room with jaundice and a fever. and a heart rate of 110. She has a 1-month history of weight loss and intermittent general malaise. Bedside ultrasound shows a gallbladder with no stones, shows a dilated common duct and intrahepatic bile ducts. On exam, the patient's abdomen reveals mild tenderness in the right upper quadrant. After ordering antibiotics and labs, what is next? A, formal right upper quadrant ultrasound, B, PET scan, C, MRCP, D, ERCP or PTC, E, OR for laparoscopic versus open common bile duct exploration. So she's jaundiced, she has a fever, and she's tachycardic. That's really what you need to know. So what's next for her? You got to decompress the biliary tree somehow, some way. Good. So most of you guys got this, ERCP or PTC. MRCP, again, you know, will you get that potentially at some point? Sure, but this patient's tachycardic and febrile. You need to decompress the biliary tree. And so that's why MRCP is wrong, because it's diagnostic but not therapeutic, whereas ERCP would be both. And then if you can't do the ERCP, PTC would also be both and would decompress.
Ooh,
right.
Dr. Reeland, that was an amazing tour de force, and thank you again for leading us through that. That was amazing.
Of course.
Well done, and really want to give a big thanks to Dr. Vreeland and our other panelists, Dr. Traugott, Dr. Blatnick, for an amazing overview. I also want to thank our SAGES staff, Vera and Vanessa, who were able to make this possible. And thank you for really great work. The survey, again, link is posted in your chat box there. I really would appreciate if you take just a couple seconds to fill that out and give us some feedback, which will help guide us for future sessions. And if you didn't have enough, this was just part 1. Part 2 is going to be continued in January before the ABSITE is given on January 11, 2022. Same time, same place. So a whole new set of questions there, whole new set of panelists as well, and we'll continue to rehearse for the ABSITE. Again, I want to thank you all for taking your time to participate with us this evening. I do wish you all a happy and safe holiday season. This session is recorded and will be posted in a couple of weeks, so look out for that. And in the meantime, please be safe, take care, and we'll see you in the new year. Thanks, everybody.